All right, so I'm going to continue thorax, lungs, heart, abdomen. So unexpected or adventitious sounds would be crackles or rails, I guess, or rales that they call them, R-A-L-E-S. Haven't heard that, but they can be fine to coarse, bubbly sounds that are not cleared when coughing. It's when air passes through fluid and re-expands collapsed small airways. So crackles is when there's fluid in there. And remember, it kind of sounds like the moving your hair against your ear, or the sound of, those are fine crackles, or coarse crackles, which would be the sound of Velcro peeling. So then we can also have wheezes, which is a high-pitched whistling musical sound that passes through narrowed or obstructed airways, usually louder on expiration. Then we can have ronchi, which is a coarse, loud, low-pitched rumbling sound during inspiration or expiration, resulting from fluid or mucus that can be cleared with coughing. So next is the pleural friction rub. It's that dry, grating sound. It's from inflamed visceral or parietal pleura rubbing against each other. So, that's just when the fluid is kind of not enough to lubricate those pleura next to each other, and they touch, and it gets that pleural friction grady sound. And then absence of breath sounds would be from a collapsed or surgically removed lobe. All right, so on to the heart. So the cardiac cycle and heart sounds. The closure of the mitral and tricuspid valves is the beginning of ventricular systole. So remember, systole is contraction, because diastole, relax. So that is, the contraction is the S1 sound, or the lub. You can hear that at the apex. And closure of the aortic and pulmonary valves signals the beginning of diastole, and that's the dub sound. You can hear that at the aortic area. So some extra sounds would be S3, which is a ventricular gallop, which indicates rapid ventricular filling and can be an unexpected finding in children and young adults. So we want to listen to the bell to listen to that. S4 sounds reflects a strong atrial contraction and can be an unexpected finding, but it can be expected in older adults or athletic adults and children. Use the bell for that as well. So S3, S4, you want to use your bell. Dysrhythmia is when a heart fails to beat at a regular, successive intervals. So it's an irregular pattern. So instead of like lub dub, lub dub, lub dub, it might go lub dub, lub dub, lub dub, lub dub, lub dub. So gallops are the extra heart sounds. So this is using the bell, and remember, the ventricular gallop, which is the S3, sounds like Kentucky. So it's like lub dub extra, lub dub bum, Kentucky. And the atrial gallop occurs before S1, so it's Tennessee, Tennessee. The SC being S1, S2, Tennessee. I don't really hear those things, but anyways. So ventricular gallop is S3, and atrial gallop is S4. And you want to use the bell to listen to those extra heart sounds. All right, so murmurs are audible when blood volume in the heart is increased or if the flow is altered. So you want to use the bell of your stethoscope because they're low-pitched sounds, and you will hear the characteristic blowing or swishing sound. It can be asymptomatic, or it can be a finding of heart disease. So systolic murmurs occur just after S1, and diastolic murmurs occur after S2. So, systolic murmurs occur after the ventricular systole. So think systolic murmurs after systole, which is the closure of mitral and tricuspid. So that's when the ventricles are contracted. Okay, so systolic murmurs after S1, diastolic murmurs after S2. You can also think of your blood pressure, it's systolic over diastolic, so S1 over S2. All right, so thrills are a palpable vibration that can accompany murmurs or cardiac malformation. So that is like when you put your fingers on top of an area of the heart and you feel a vibration, almost like a cat purring. Bruits are a blowing or swishing sound that can indicate obstructed peripheral blood flow. This could be in like the carotid arteries. So bruits are basically murmurs that just aren't in the heart. It's just in another place. So that's that swishing sound again, and you use the bell of your stethoscope to listen to that because it's low pitched. Remember, it's just like a murmur, but not in the heart. All right, so we know all the auscultatory sites. Review of systems, you inspect, you palpate, you inspect for any vein distension, jugular venous pressure. You can measure about a little less than 1 inch above the sternal angle. That ruler technique. You locate the pulse of the external jugular vein and you place the straight edge of another ruler parallel to the floor of level of the pulsation. All right, so, and you always want to remember, only examine one carotid artery at a time so the patient doesn't lose consciousness from a result of inadequate circulation to the brain. All right, so the heart. The PMI, which is the point of maximum impulse, that is the apical pulse. It may be visible just medial to the left clavicular line at the 4th or 5th intercostal space. You might have to displace the breast tissue in female clients. Palpate where you visualized it. Otherwise, try to palpate the location to feel the pulsation. So it's usually around like Erb's point or the apical pulse. It's just at the mitral area, so midclavicular line. All right, so auscultating the heart, having them lean forward for any extra or abnormal sounds, and they lie supine, lie to the left for any extra sounds or murmurs, using the both diaphragm and bell to listen at all the sites. This book says to listen and count for 1 full minute. Determine if it's regular heartbeat. If there's a dysrhythmia, which is the heart failing to beat at regular successive intervals, check for the pulse deficit. So that's the radial pulse and the apical pulse, and report the difference to the provider. So it's 1 full minute. You can't do 30 times 2 like the book. 1 full minute at the apical pulse. All right, so peripheral vascular. If we remember, carotid, abdominal aorta, which is just below the xiphoid process, renal arteries, which is above the umbilicus on the abdomen, the iliacs, which is midclavicular line below the umbilicus, and femoral arteries, which is right over the femoral pulses. All right, on to abdomen. For quadrants, you want to move in the horizontal lines, having the xiphoid process as the upper boundary and the symphysis pubis as the lower boundary. Again, you want to review systems, nausea, vomiting, cramping, change in appetite, surgeries, injuries. If they have alcohol, what do they drink and eat during the day? Any bowel or stomach problems, any medications, constipation, uses of laxatives, any of that stuff. So, while you inspect, you always want to note any guarding or splinting of the abdomen. Inspect the umbilicus for position, shape, color. You assess the skin for lesions, bruising, rashes, scars, striae, dilated veins, jaundice, cyanosis. Shape or contour of the belly should be flat. It also might be convex, which is rounded, concave, which is sunken. Think of a cave in a wall, it's sunken in. It might be distended. It might be due to fat, fluid, or gas. It is fat if they have rolls of fat tissue along their sides. It might be fluid if the flanks also protrude. When the client turns to the side, it might move. Might be gas if it's mainly midline and no change in the flanks. A hernia is a protrusion through the abdominal muscle wall and are visible even when the client, especially when the client raises their hands overhead. All right, so you want to notice any peristalsis, pulsations, listen to bowel sounds. Normal active is 5 to 35 times per minute. So unlike our school book that says 30, this is 35. So 5 to 35. To make it, if you don't hear any bowel sounds, you must listen for a full 5 minutes to make sure you don't hear any. You can't just say, oh, 1 minute, didn't listen. 5 full minutes. Some unexpected sounds. Well, hunger is borborygmi. I'm not exactly sure how to pronounce that. It's BORBORYGMI. Those are hyperactive sounds and can indicate increased gastrointestinal motility. That might be because of diarrhea, anxiety, bowel inflammation, or reaction to some foods. Also, if you're hungry. Friction rubs, that means that there might be inflamed layers, and you want to listen over the diaphragm of your bell, over the liver and spleen. Listen for that grating sound. Percussion, you want to hear timpani. All right. Sorry, just 1 second. All right. Okay, so abdomen, you want to hear timpani. And you can, if you're advanced, you might be able to measure the liver span or establish the borders. So the expected finding is that the liver is 6 to 12 centimeters or 2.4 to 4 to 7 inches. You can assess for kidney tenderness by fist percussion. So remember, at the scapular lines on the back, you put your fist on the patient's back and then you hit your fist with your own hand. And if it's tender, there might be kidney distension. All right, so lastly, we're going to palpate. So light palpations, just about half an inch in each quadrant, should be soft, no guarding. The bladder might be palpable if it's really full, if not, non-palpable. If you want to do any two-handed approach for a deep palpation, you do the hand on hand, and that goes like 1 to 3 inches in. That's just assessing for organ enlargement or masses, and you might be able to palpate in the descending colon any stool, so that's normal. So Blumberg's sign or rebound tenderness is an indication of inflammation somewhere in the abdominal cavity. So you apply pressure for 4 seconds with the hand at the 90-degree angle with the fingers extended. After releasing pressure, observe the appliance response to see if the pressure caused any pain. All right. So, any expected changes with aging for all the systems in this chapter: breasts, the glandular tissue atrophies, and adipose tissue replaces it, making it softer and more pendulous, which is them hanging lower. Their ducts might feel like thin strands. Nipples might not be erect anymore, and they can actually invert. But of course, you always just want to make sure inverting is not an indication of any breast issues. Lungs can change shape, so the AP diameter can be similar to the transverse. Remember, it's supposed to be 2 to 1. It can give you a barrel chest. Cough reflex might diminish. Cilia ineffectively removes dust. Alveoli dwindle, so the risk of pulmonary infection increases. Kyphosis, which is an increased curvature of the thoracic spine due to osteoporosis or weakened cartilage, can result in vertebral collapse or an impairment of respiratory effort. The cardiovascular system, they might get systolic hypertension, which is a widened pulse pressure. The PMI might be more difficult to palpate because the AP diameter of the chest widens. Cardio output can decrease. Heart valves can stiffen due to calcification. Left ventricle thickens. That's commonly seen. Left ventricle thickens. You want to think the left ventricle is working harder, so that's why a lot of people have left-sided heart failure, because the left ventricle is taking all the blood to the entire body, and the right ventricle is taking it to the pulmonary, so it just has to go to the lungs. Left ventricle has to pump it out everywhere else. They might have an increased systolic blood pressure. Their peripheral circulation diminishes. They may have weaker abdominal muscles, giving it a more rounder, protruding abdomen because of more adipose tissue. A lot of secretions, gastric, saliva, pancreatic enzymes decreasing. So, yes, that is it. I'm going to flip back really quick and just review a couple things I said. Remember, with thorax and lungs, alright, you want the expected sounds when we auscultate: bronchial over the trachea, bronchiovesicular over the larger airways, and vesicular. That's over most of the peripheral areas of the lungs. Unexpected sounds: crackles. That can be through fluid, the air trying to go through the fluid. They can be fine or coarse. Wheezing is that high-pitched whistling, musical sounds. Rhonchi is coarse, loud, low-pitched sounds. Those do clear with coughing. The pleural friction rod, that's that grating sound from inflamed visceral or parietal pleura. Alright, and then again with the heart sounds. So S1 is lub, which is ventricular systole. S2 is dub, which is ventricular diastole, or the relaxation. S3 is that ventricular gallop, and that is indicates rapid ventricular filling. S4 is a strong atrial contraction. Gallops are extra heart sounds, and you want to listen to use the bell because they're low pitched. Systolic murmurs occur after S1. Diastolic murmurs occur after S2. Alright, I think that is it for right now. Alright, done.